Yeah. So we have Dr. Mithun Tulsidas is here already. Flow capsulorhexis, a novel technique in white and hypermature cataract. Over to you, Dr. Mithun, please.
Respected Chair and Delegates, good afternoon. Today I'll be presenting on flow capsulorhexis, a novel technique in white and hypermature cataracts. I have no financial interest. So as we all know, attainment of a continuous curvilinear capsulorhexis is challenging, especially in white intumescent cataracts. And the incidence of incomplete capsulorhexis ranges from 3.8 to 28.3 percentage. So many techniques have already been advised in the literature to perform capsulorhexis in such cataracts. These are the following. So I just introduce my simple humble technique which can be added to the surgeon's armamentarium. So in the present study, a modified flow capsulorhexis technique is described. And if you are introducing anything new, you have to compare it with a standard technique. So I have compared it with the standard needle decompression capsulorhexis by Bhattacharjee and Nabil. So this was a retrospective study over 30 months, analyzed the data of patients with intumescent or non-intumescent mature white cataracts who had undergone either phacoemulsification or manual small incision cataract surgery. So the intumescence was diagnosed based on the presence of a shallow AC or the presence of fluid vacuoles or radial spokes in the anterior cortex or the presence of multiple acoustic internal reflections on ultrasound A scan. Pediatric cataracts and those with retinal or optic nerve pathologies were excluded. Group 1 included those who had undergone flow capsulorhexis and Group 2 included those who had undergone needle decompression capsulorhexis. So this is a small video which shows the technique. So this is a very cost-effective technique which can be done in any setting. So you're just attaching the bent 27 gauge cystitome to the infusion line of the balance salt solution and the flow is kept open. Now you can either choose the main tunnel or the side port based upon the surgeon's choice. Here I am just showing the main tunnel to just show that how the AC is well maintained even when you're going through the main tunnel. So here there is a continuous flow of fluid from the tip of the cystitome which actually washes away the liquefied cortex. It maintains the AC without collapsing. And also you need not go in and out in such cases because that is when you have to inject viscoelastic. Here you need only minimal viscoelastic or sometimes you don't need a viscoelastic. And you get almost a perfectly centered capsulorhexis. This is a kind of not very intumescent cataract. Now no technique is 100% accurate. So here is a case of phacoemulsification where again I am trying through the main side, main wound. You can see the liquefied cortex is automatically getting washed away. You don't need any other additional instruments. So it actually does the work of an AC maintainer without an AC maintainer. The flap is rotated. You can see it's extended to the periphery, but as it's a small pupil and the flap motility sign, I'm pretty sure it didn't extend to the periphery. Using a microrhexis forceps and scissors, I'm just completing the rhexis. This is another case which is very intumescent. That's a hypermature cataract. You can see the flow of fluid from the tip of the cystitome. You can actually titrate the flow also based upon your choice. You can just adjust at the flow. Now again, the cortex is getting washed away automatically. So most of the time when you inject viscoelastic in between, when it gets mixed up with the liquefied cortex, it hampers the clinical visibility. Here we don't have that issue also. The visibility is well maintained. That is a calcified area. There was small resistance, but eventually I could get away with it. So this can be considered as a stable new option along with other techniques for white cataracts. So the outcome measures included the success rate, which is defined as a single stage, circular, well-centered capsulorhexis without any extension, completion time of CCC and times of viscoelastic supplement. These are the statistical methods used. 608 eyes of 420 patients were included in the study. Group 1 had 312 eyes and Group 2 with 296 eyes. There were no significant difference in the demographic characteristics between the groups. Coming to the outcome measures, you can see the completion time of the capsulorhexis is relatively less in group 1, that is a flow capsulorhexis, which is significant statistically, and the times where you have to inject the OVD in between is also less. The success rate is 95% compared to 87% of the needle decompression technique. Like I said, no technique is 100% accurate. There was peripheral radial tear out, like the case which I showed in phacoemulsification in 4.2% of group 1 and 12% of group 2. 2 eyes had PCR and 1 eye had a ZD, but those were not related to the technique of the capsulorhexis. The distance visual acuity was more than 6/9 in all the eyes. So these are different techniques which are already described in the literature. So I just introduced my simple, humble technique along with it. And it was observed to have statistically better outcomes in terms of completion time, OVD supplement time, and success rate when compared with needle decompression technique. So this is fast. You need minimal viscoelastic device. The most important one is it does not need any additional instruments. It is very cost effective and it is easy to master even for a neophyte. So this study describes a new technique, compared it with an established technique, relatively larger sample size. However, retrospective design and subjective analysis are few of the limitations. To conclude, this is a novel technique for performing safe and successful CCC in white and hypermature cataracts. It is fast, economical, and reliable. Thank you for your kind attention.
Very nice presentation. Good idea, Dr. Mithun.
Thank you.
Just had one point. When you are doing a Rexus, so I think wouldn't you feel better that doing through the side port
Yes, sir.
is much more better than going through the main wound? The first video you showed,
Yes, sir.
there was a scleral tunnel,
Yes, sir.
and of course, while driving out the intumescence or whatever material, milky material is there, that is okay. But after that, would it be better if you had approached the chamber stability would have been much better
Yes, sir.
using a side port rather than the main port? I
Yes, sir.
saw,
Even in this study, I have done most of the cases via side port only.
but the
Just
videos which you
the
showed
video
were
with
all on the main ports.
because to just show the stability of the anterior chamber, because side port anyway the
And
chamber will
second
be
thing
more
is,
stable.
the Rexus runout happened in
Yes,
one
sir.
of these
Yes, sir.
cases.
Yes, sir.
So what happens, what I feel is, when you are trying to depress the lip,
Yes,
that
sir.
time the flow rate will not be accurate as what you set it.
True, sir.
The fluid keeps coming out.
Yes,
So
sir.
the chamber stability will not be again maintained, which
Yes, sir.
probably would have been maintained with a
With the side
viscoelastic.
port. Yes, sir.
So
Yes, sir. Like we said, like we might need viscoelastic in few cases also. Like
yeah,
suppose if it's a phacomorphic glaucoma, there is no way you can always get away with this technique. It is just one addition to the already established techniques, but still it is again 4% there was peripheral radial tear out, almost 13 eyes.
where you had to use the forceps to bring it
Yes,
back.
forceps and viscoelastic.
Like one comment on this, instead of mixing both hypermature and intumescent, because intumescent will have more tendency for extension
yes.
to the periphery, and
Yes.
you have mixed both
Yes, sir,
hypermature,
we can do
that
as
fluid will come out, and then you can make
Yes, sir.
Rexus easily. But
And we have-
intumescent always there will be chances of extension.
yes, sir.
So you should have
All these
separated.
13 cases were in intumescent category only. All the radial tear outs were in intumescent.
With an excellent presentation. You have mentioned the strengths and limitations of your study.
Yes, ma'am.
You have spoken about the advantages of the procedure. Do you think there is any disadvantage that you can mention here?
Yes,
Because
ma'am,
every
this-
procedure has their pros and cons also, you know?
Yes, ma'am. The main disadvantage is the same, ma'am. Like this is not 100% accurate. Like we need more data because this is a single surgeon data which I am showing. So you need data from
No,
multiple
disadvantage for the outcome of the surgery. You know, embracing this particular surgery. Is there any other disadvantage that you would want to tell us?
No, ma'am. Regarding the technique or the study, like
Not the study. Study, I understood
Yes,
the
ma'am.
limitations. I'm talking about the technique. You spoke about the disadvantage of, advantages of the technique.
yes,
So is it like no disadvantages at all, according to you?
disadvantages comes with the case, ma'am. Like
Okay.
we are not using anything like specific to, because this is already available in OT. You're not spending any cost or you're not depending upon anyone. So the disadvantage is basically it may not work in all the cases because depending upon the case, like sir said, if it is too intimus and if it is a very hot eye, then there is a chance of failure. So when we take the opinions from different surgeons, we can know how to improvise the technique or do something along with it so that we can get more better outcomes.
All right. Thank you so much.
you.
Yeah. All the best.
Okay, thank you, Dr. Mithun, the wonderful presentation.